shock. We do not need to run for local anesthesia because this cut is very painless. So this is the medial ankle here, and just anterior to this we're going to make the incision. And after having come through the skin, we make the blunt longitudinal dissection, like this. And in the midst of this structure, we hope to find the vein. It comes here beautifully. It's actually here. You see there's little blood here. This is the saphenous vein. We try to liberate it a little bit more without disturbing it. So this is a saphenous vein, and we take one thread below it like that to the distal side and keep it there. And then we take the other one and make a proximal similar sling so that we can keep the vein up. And these two slings help us to identify the veins. Now I'm taking the distal one. We lift the distal sling and we make a small partial cut with the scissor. Should be just half the vein, like that, to open it like a hole like that. And now I'm into the vein. And now I ask my assistants to give me the tip of the needle. And this is again with a very important obliquely cut end, and we introduce the tubing, and it runs smoothly into the vein like that. You can follow it up. It goes into the vein. We stretch the vein a little bit. Now it's in 5 centimeters. We should have it in a little bit more. Now it's up to 8 centimeters more or less. Then I take the proximal thread and I tie it firmly so that the proper tubing is fixed into the vein, like that. So now it's there, and I ask my assistant to compress. This is important to see the flow, the virtual flow. There are no drops seen, but you can see how many milliliters of volume is going into this woman's body. You can see that here is nothing going outside the vein. Everything goes inside the vein. As this vein, you can see here, is filled with fluid going into the body. And this is a very efficient way of getting blood or fluid. And soon we have 1/2 liter in, and we can put another bottle in. And after, we can shout for blood or other better fluid in order to save the life of that woman. After having given this fluid, we can actually try to fix the whole thing and make the suture of the skin. And then I cut the ligature here. I can leave it in place, and then I make the suture of the skin, which is just to make it a little bit less disturbing and avoiding infection. In real life, in the obstetrics, we cover this with this wound with adhesive, and then we keep it, and it can be kept for 1 day or more. Now, with the respect for the dead body, we should be very careful in leaving the whole thing in a very neat way and withdraw the tubing. And I think we can do it right now after having shown it, so we're not leaving the dead body with the tubing inside. So let's go back and take it away. And I can actually retract the tubing like this from the dead body. It will follow easily, like this. And this is the needle again. And we can say that this small incision will leave a very, very minimal mark on the body. And this is the whole exercise, which is very important for any midwife in the world to perform without doctors. for any non-physician clinician, be it assistant medical officer or clinical officer or anyone working in the labor ward with very severely ill mothers after postpartum hemorrhage.